I do want to acknowledge that we've been talking throughout the afternoon about the really very profound impact on all, not only all of us, but in particular communities of color in New York City. And it's by no means a new issue, but I think as we've learned from, frankly, past epidemics and past disasters, communities that are most disinvested in, most disproportionate impact of adverse health outcomes, yet again are really bearing the brunt of this pandemic. And many of the investments and strategies that we've already heard about, even though I'll be talking more about mental health and substance use, really are some of the very same strategies to improve health outcomes for folks in this domain. So what we do know from other emergencies is that mental health really can be significantly affected by emergencies. I think this emergency has some unique features that pose particular risks. The things that protect us from the pandemic, like physical distancing, are the very same things that might predispose people with behavioral health conditions to worse outcomes. We know from past emergencies and national data that folks in emergencies and following experience increased risk of anxiety, depression, increased risk or use of substances. And we expect to see some of those things here as well. I think one difference when thinking about behavioral health is that sometimes the effects can be delayed and more protracted, even after people get through the acute surge as we saw it, and we're learning more all the time, in fact, about the longer-term physical effects. We know from other emergencies that the impact on mental health can last for long after the surge has passed. And so I think both just even knowing that information is part of our approach, and I'll speak more about some of our other approaches, but really educating ourselves and New Yorkers about what could be a normal reaction to this really difficult situation actually can help people move on the road to recovery.
I'd like to also move over to Bill. Can you give us a sense of just the impact to the elderly population?
Yeah, the prior panel talked about communities where there's been considerable disinvestment, and the Foundlings' work is largely in those disinvested communities. And quite frankly, we're very, very worried. I mean, the idea about PTSD is actually what we're going to see from a behavioral health perspective here. I don't think there's any doubt about it. The Foundling does a ton of work in Puerto Rico. We serve 1,500 families there. And we're starting to deal with families from Maria to the earthquake, families who are now just coming out and talking about their experiences. There's no reason to believe the same thing's not going to happen here. And we have an access problem. We have a capacity problem, and both of those problems impact communities of color, those communities where there's been disinvestment, much more than they do the other communities. So my view is that someone on the prior panel said, let's not waste this crisis, and you should never waste a crisis. I think there's some silver lining coming out of this and some things that we've learned through the pandemic about interventions in the mental health world that I think will be of considerable value to us. I think that if we don't take a more rigorous critical look at telecare, and I just don't mean telepsychiatry and telehealth, but telecare, whether you're a caseworker in foster care, a caseworker seeing families whose children are at risk of being removed and placed in foster care, we have found through the last 6 months that telecare has been invaluable. And let me say a nice thing about our public partners. Through the pandemic, they have been very, very accommodating about the role of telecare. We run the risk, though, and the prior panel touched on, we run the risk after the pandemic's over, everybody wipes their hand and say, let's go back to business as usual. We can't do that. We learned some things through this. We learned that technology can be our friend here if we use it wisely. And too often the proponents and the critics say it's an either or. This is not an either or. This is an integration about approaches to caring for these people, because I'll tell you, the mental health issues emanating from this pandemic, particularly in disinvested communities, is going to be with us for years to come.
Before we move forward into more solutions, wondering, Charlotte, if you could talk a little bit about the impact to children and families, especially as we are going back and forth between opening school and there's really no certainty for a lot of families in terms of, will my kid be able to go back to school and get a lot of the services that they might have been getting in schools before? Where do things stand with that, and what are potential long-term impacts? Charlotte, you're still muted.
Sorry. I heard others speak about access, and that certainly is one of the highest priorities. As we had to pivot to remote care, many people took for granted that every family has access to devices where they could have telecare. So we're not just talking about computers and bandwidth, but some folks don't even have smartphones. So it's something that people have to consider, and certainly that decreases access. We've also seen serious threats to high-risk populations like those in domestic violence situations, children in foster care, as Bill described. And we've also seen that there has been a reduction in access due to lack of beds and inpatient care, because those resources were repurposed to deal with the pandemic. And it's not just space, it was also staff. So staff were dealing with the issues internally in the hospital having to do with healthcare workers and families and people who were not able to visit loved ones who were sick and dying. So, you know, that certainly has a big effect on the baseline for this generation of children. Anybody who had mental health issues now lost every coping mechanism in our society as it existed. And so as those things like school, playgrounds, gyms, churches, all sorts of resources were unavailable or dismantled, anxiety is going up and the ability to cope with it is going down.
Senator Carlucci.
Well, thank you for having me. It's great to be with this distinguished panel, and to just follow on what some of the previous speakers have spoke about. It's very concerning for all of us in the mental health and disability advocacy arena. It's taken decades to get to where we are. And we've tried to take services and treatment to the time and place that's appropriate for people. And now society and the norms have all been twisted sideways and upside down. And we have to reimagine what access, what it looks like to get help. I've been talking with colleagues in the legislature and friends, and I tell them that we see that reports of neglect and abuse are down by 50%. And normally this time of year, we would see a spike. And people start to say, oh, well, that's great. And we say, well, no, we're very concerned, because the normal procedures that we have in place are now not viable. And so there are many concerns that we have, and there's some that are not as noticeable right now. And that's why we really have to embrace the new environment that we're in. We have to use teleservices to their to the utmost that we can. And some of the ways that I see it is that we need to get into in front of as many children as possible. And if we're doing physicals, you know, we ask for a vaccination schedule to be completed. We should be using telehealth to have mental check-ins with our students, to have a screening so that we know, we can see maybe it's possible that this child is being neglected or being abused, or maybe there is just some early intervention that we can do. So we know that there is so much to be done. And I remind my colleagues in the legislature that in New York, we have a responsibility. I serve on the board of the National Conference of State Legislators, and I get to talk to legislators from all over the country. And sometimes when I tell them that I chair the Mental Health Committee, they say, "You have a committee for that?" And it's a little disturbing to know that we have so much work to do in New York, but to see how far ahead we are in New York. And that's why in this crisis, we have to re-examine pretty much everything. And there's a lot we can do. We have a stack of bills that we're looking to pass before the end of the year. We have legislation that's sitting on the governor's desk right now that we just passed in July through both houses. And that's the trauma-informed work group for the Office of Mental Health. The idea that was said before that post-traumatic stress is going to be a major issue, particularly for our frontline workers. And we have to have best practices in place to make sure that any barrier to treatment, any barrier to resources is knocked down right now. We need to be proactive. We can't wait for the storm to arrive. We need to get in there as soon as possible. That's just one thing of many that I think we can do in New York.
Council member.
Well, thank you, Aaron, and it's really an honor to be part of this discussion and great to be with my colleagues. I represent a district in northern Manhattan that includes parts of Washington Heights and West Harlem, and the impact here of this pandemic has been devastating. We've had hundreds of fatalities, many times that number in long-term disability, and this is still today, we're seeing ongoing inequality. The positivity rate in uptown Manhattan is triple at least what it is relative to wealthier parts of the city and state, approaching 2% here uptown. And of course, the economic impact as well, and unemployment and small business. And yes, this has impacted mental health, undoubtedly, together with isolation and anxiety. I am particularly concerned about what this has meant for people who are struggling with addiction, because of many of the treatment services have been disrupted, even things like AA, Narcotics Anonymous. Many of the services offering medication-assisted treatments have been disrupted. Many of those who are consuming narcotics are doing so more likely alone at home, and so there's no one there to administer Narcan or to call 911. The supply chains of narcotics have been disrupted, and people are using less pure and more deadly forms. And anecdotes at this point to a pretty sharp increase in overdose fatality in New York City. We don't yet have current data on this, unfortunately, but we have reports from FDNY, which runs EMT, about significantly elevated incidents of overdose death and administration of Narcan by EMTs in New York City. So I think all of us are expecting that when we do begin to get numbers on this, that it'll be painfully high. Quite frustrating after the progress that we had been making on dealing with addiction. I think 2019 was really the year that we leveled off and started to see a decrease in overdose death and opioid and other death in New York City. And the signs were that in early 2020, we actually saw a real decrease. But I fear that progress has been lost, and that we're now moving in a scary way in the wrong direction. This has to receive greater priority as we think about rebooting our health system, behavioral health more broadly, which I'm grateful this panel is focusing on, but specifically treatment for those who are struggling with addiction needs to be on the agenda and given a high priority.
So it seems that we need to find a new normal. There's really no vaccine available yet, no really good treatment right now for COVID-19, and yet these services, many of them have been paused. We got a question from Angela Kedzior, who wants to talk about the loss of psychiatric beds, the closure of detox beds, adult daycares have closed. How can we get back to that new normal? What needs to be done? And I'll throw that over to Dr. Cummins.
So So these are great questions, and I share Councilmember Levine's concerns, although we don't yet have data. Some of the data that we would usually rely on, have been delayed in the context of the pandemic. In response to that question, though, I first want to point out how many services continued to operate in person really heroically through the pandemic. Shelter providers, congregate residents for people with developmental disabilities, residential and adult care facilities for folks with mental illness. And I just want to acknowledge those many providers. I think there's been a lot of appropriate kudos given to, very importantly, the nurses and doctors working in hospitals, but these folks and caregivers in congregate settings and the providers and supervisors, so many of whom I spoke with during the crisis, really carried on. They were adaptable, inventive, creative. We were at the City Health Department, had webinars, countless phone calls, trying to support providers to problem solve. And I really want to call out in particular that the extent to which we all became COVID experts. None of us started this pandemic, obviously, knowing about this novel virus, and in particular, the behavioral health sector is not always accustomed to dealing with physical health problems, infection control, physical distancing, separating beds, and the work they did was extraordinary. And we at the City Health Department and the city all together worked hard to try to support those providers. So lots of things continued. I just want everyone to know that. The other thing that also is happening is there are providers beginning to essentially reopen in ways that the rest of the city and the state is, as the prevalence, as our successful decrease in prevalence has continued, and really thinking carefully about where care can happen in person and where sort of on the benefits and risks ratio, benefits outweigh risks. So many things have reopened, not everything. And I think every decision is being considered and thought through. And we are trying to offer guidance and problem solve as new issues come up. And I think this is part of, I think, as the telehealth conversation reflects, is so many things have continued in different ways and these are unbelievable opportunities to engage folks that in new ways, in ways that we didn't realize would work, that we are all trying, both as government and as providers, to implement and to care for people. And I'll just kind of point out, I was just on this virtual conference this morning of peer workers in New York State, together with the Office of Mental Health. The City Health Department sponsored a conference with workshops and hundreds of attendees who are continuing to think about and do the work to support New Yorkers that they did before the pandemic. And these are folks who with lived experience, seeking to deliver support in some of the same ways and also new ways.
Councilmember Levine, wondering if you could discuss efforts that the City Council is working on to promote positive programs and resources for mental health.
Absolutely. I mean, our first fight is the budget, and we've worked really, really hard to avoid cuts to mental health services during this time of crisis. Turns out that every category of funding has a case to make for why it's uniquely important, but boy, I think mental health, it's just impossible to argue with the urgency right now to at least hold it steady, ideally even to increase this. And so for some of the City Council initiatives, which we have particular control over, we were mostly able to hold them to little or no cuts, everything from autism awareness to LGBTQ mental health. That fight continues, but so far we've largely been able to hold the line. But looking forward, there's a number of interesting bills that are moving. Actually, there's a hearing in the Mental Health Committee next week, and just like in the State Senate, the City Council has a standalone Mental Health Committee, which is chaired by my amazing colleague, Councilmember Chair Diana Ayala. And they're looking at several pieces of legislation, one by my colleague, Farrah Lewis, that does try and get at the data issue and is going to require regular reporting on mental health incidents during the COVID era, something that we don't totally have eyes on right now. We have much better reporting on traditional health than we do on behavioral health. And so my colleague, Councilmember Lewis, has a bill that will be heard next week at this hearing. There's also a piece of legislation by my colleague, Richie Torres, that is really going to try and bring in youth-serving nonprofits more into mental health work by requiring that the health department compile a list of all the mental health services available for young people, for adolescents and young adults. And then all the contracted youth agencies in the city would be oriented on them and get direct access in real time to those services to try and have a seamless integration. So a couple good pieces of legislation and I think a broad commitment in the council for the long-term fight ahead. As Bill mentioned, this is not going to be quick. We understand that. And in fact, the worst is likely to come. What you learn from people who have come out of war, who are dealing with PTSD, is the hardest moments is when they come back home to the family and the adrenaline stops pumping. And then they have no choice but to confront their challenges. And I'm expecting that will be an ongoing crisis for healthcare workers, for regular New Yorkers for months and probably even years to come. And I think my colleagues are committed to be in this fight for the long term for that reason.
Senator Carlucci, we've heard there's likely to be very large cuts in spending at the state level. Mental health services have been chronically underfunded. So what can be done, what is being done by the state legislature to try and preserve funding for mental health services?
Well, we need to continue to advocate as best as we can. We know that we have looming cuts across the board for every part of the state budget in New York State. And that's why the federal advocacy is going to be so important, that the federal government does its part in providing money to the state and localities. That's without question. Within that, we can work towards some of the changes in regulations that we've talked about. How do we streamline the process for telemedicine and telehealth? These are the important things that we have to stay focused on. One of the things that I'm hopeful that we can see through, in some of these things, it might be, penny wise, but pound foolish. And that's the wages that we pay to our direct service professionals. Now, we need to make sure that we have a viable workforce that wants to do this work, that can do this work. We've had major challenges. Now with COVID on top of it, we have to make sure that we have a well-trained and dedicated workforce. When you're paying minimum wage to do some of the hardest work there is, that's a recipe for disaster. So one of my dreams really is to see a credentialing program for our direct service professionals, that they actually get paid for their longevity, for their experience, and that we could have a system that's directly linked to Medicaid that recognizes that if we have a well-trained workforce, we're going to have better outcomes. We have to see through that. We have to make sure that at the end of the day, we are making investments in what's most important. We have to remember that it's people helping people. And even with technology that we've all had to embrace, we have to remember that it takes someone to work that technology. And when we're talking about the field of behavioral health, when we're talking about social services, we have to have a dedicated team that's going to really work through the bureaucracy. And so many times we hear the disaster stories, and sometimes it has to elevate to a dramatic level. But we hear about where bureaucracy just failed. And now is the time that we have to reimagine what it looks like to deliver services and do it in a new way that's efficient, that's effective, and really delivers those services. I mean, some of the things that we see, we're worried about an increase. We've talked about abuse, neglect, addiction, issues like eating disorders that have long gone, unfortunately, undiagnosed for so many New Yorkers. That's going to continue to exacerbate. And as long as we still continue our healthcare model under the old way, without social distancing and shutting down schools, we're going to be way behind. So I think it's time that we reimagine it. We leave no stone unturned. The other day, I had a roundtable with direct service providers, and we talked about what are some of the things that we can do. We know the funding is a big issue, obviously, but there's other things that we can do right now that could really make a difference. And those are some of the things I look forward to getting done before the year is over for New York State.
Bill, you look like you want to chime in here. Do you have wanted?
Yeah, I tell you what, I thank God for Senator Carlucci and Dr. Coonens, first Dr. Coonens, for talking about, we provide residential care to 500 developmentally disabled adults. And our staff, what they did through these 6 months, we lost 10 clients to COVID, 40 staff actually contracted COVID, yet those houses remain staffed. And actually, Senator Carlucci talked about the direct service professionals. This is actually DSP week. We're in the middle of, this is the annual this week, and tomorrow we'll have our celebration for our 700 DSPs. And so I want to thank both of them for acknowledging that. But listen, I can't change what happened yesterday. Here, we're concerned about the long view and what have we learned? How are we fundamentally going to change our approach to the people we care for? A couple of things. We've long felt that from a behavioral health standpoint, clinic practice is overvalued. We actually think clinic services fail to take into consideration context, and social context to us is very important, particularly given the kids and the families we serve. And I think social context is even going to be more important coming out of the pandemic, because for good or for bad, right, families have spent a lot more time together. And the challenges both the adults and the children are going to have are going to be the product of what that relationship was like. What I found out about him, what I found out about her. And I think if we stick to the traditional clinical approach, clinic-based approach to these services, we're going to miss something very, very big. So we believe that clinicians need to get out into the communities, but government needs to be our friend here. The billing practices, again, post-pandemic, and government has been very accommodating through this, but going forward, I mean, just the way you bill for Medicaid, right? People, you bill for a child, you bill for an adult. No, it's not about a child, it's not about an adult, it's about a family, right? A 7-year-old child has a caregiver, whether it's a mom, a grandma, an uncle, or a dad, they have a caregiver. And so the challenges that 7-year-old has is a result of the relationship that they have there. You need to start to recognize familial context in the care of these kids. So we're excited. We think there are opportunities. The needs are going to be great. The senator talked about, schools again. Today we heard that there's going to be a delay, and everybody says, oh God, and we operate a charter school, so I don't like to see any delays. But you know what I worry about? The thing that Senator Carlucci said. How much more abuse and neglect is going to occur that we're not going to know about as a result of school being delayed? He was right. The reports to the State Central Register go down during the summer with school ending, and they go up in September when school begins. The longer we extend that, because you're not going to find that out through virtual education, trust me, the abusers will make sure you don't find that out. So more and more kids, we need to be prepared to respond. We need to be prepared to respond. And so that's the kind of processing we're going through here. And I'll tell you, I don't want to oversell it, because I do think there's a risk of that. But we're working together on an integration on how the touch points, how telecare can increase the volume and the nature of our touch points with families, whether it's through initial engagement or sometime during the conduct of their time with us. So we're excited about the challenges, but we're not naive. we're in for some rough sledding, all of us, in this work, and it's not going away tomorrow.
Charlotte, wondering if you want to weigh in on some creative solutions to sort of buffer some of what we might see in terms of long-term harm that could happen as a result.
Sure. One of the things that's been very helpful, both from a county level and a state level, is some flexibility. From the state having the regulatory waivers around the billing documentation and being able to bill for telehealth services across the board. Our agency went from about 5 to 7% of our business being telehealth to flip-flopping to about 99% of our business being telehealth. And so that's remote across the agency, except for places where you have to do things in person, because you can't do substance use swabs from a distance. You can't give long-acting injectables from a distance. You can't take blood work for Dilantin levels from a distance. So different things like that, our staff had to come in. And I just want to echo, not just at MHA Westchester, but across agencies, across the state, how many people showed up despite the circumstances and the conditions to work in situations where they were experiencing vicarious trauma, working with clients who were facing extreme poverty, death, loss of all kinds, and illness. And, we really appreciate that flexibility and hope that it goes forward in the future. We also receive flexibility locally from our county in being able to use the funds that we get for traditional programs to do some things differently. So, for example, we were able to use money to do disinfecting and cleaning, to buy IT equipment, because we certainly didn't have equipment for all 350 of our staff to be able to provide remote services. We also did things like in our Sterling Community Center, where people usually come on a daily basis, and it's the only place where they would get socialization and sometimes the only hot meal that they would get. We converted that to a mobile food pantry, and our peers were then going out to people's homes from a distance and with PPE, but being able to make contact with people and getting eyes on people to make sure that they were okay. And we've been doing that with our families and our children as well. So the key for me in being able to balance the future services is having a combination of remote work together with some work in person. We've gotten lots of positive feedback from our families and children that they do like the telehealth services. They like the remote services because it removes barriers such as transportation, childcare, somebody who has anxiety issues, who has difficulty traveling to a bricks and mortar clinic. So I appreciate what Bill said about that, kind of antiquated 45-minute session of psychotherapy. That isn't the cure-all for everybody. Some people need food in their refrigerator. Some people need support because they're being affected by the violence in the anti-racist movement. And so having social determinants of health covered under behavioral health and health care, those kind of things, and that kind of open-mindedness is needed going forward.
I guess, it's come up a lot, seniors are increasingly isolated. There is expected to be an increase in loneliness and depression and anxiety. What specific guidance, and I'll open this up to whoever wants to answer, would you give to senior citizens who are going through this right now, and maybe even to their neighbors, to the communities that surround them?
What I would say early on when we saw the pandemic approaching and we were worried about the food banks and we've seen a great need. And you just combine that with some of the federal policies, the changes in SNAP that happened earlier this year before COVID, it's exacerbated the situation. But one of the things I think we have to push government to continue to do is fund programs like Meals on Wheels, where you're actually physically delivering meals. You've seen a push for a long time to do these basically frozen meals where people will stock up on them. It's a savings to the local government in terms of dollars there, but another example of being penny wise and pound foolish. We know that that interaction, as minimal as it is, it's a big step. And just knowing someone's routine and being able to check in a little bit here and a little bit there goes a really long way. And if I could just say one thing that the council member touched upon briefly about medical assisted treatment. And I'm hopeful when we talk about reviewing the regulations. For a long time, I've been very critical of our methadone practices, basically our federal regulations, but also some of our state regulations. And I think it's time that we allow for more flexibility and ability for people to self-dose. Where I am in Rockland County, we're just outside New York City, but you have a situation where people have to take hours out of their day just to go visit the methadone clinic. They can live productive, successful, independent lives, but it's a major drain. Add COVID on top of it, it's a disaster. Many times things don't change until it is a crisis. It is a disaster. It's been that way for a long time, but I'm hopeful that that's another thing that can change and make medical assisted treatment, things like methadone that have been around for a long time, but making it more accessible to people could be a blessing from this crisis.
Yeah, if I can jump in here also, Erin, as you know that this is something that's been really important to our work at the City Health Department. And I just want to echo what the Senator just said, which is one of the silver linings, if we want to use that word, of the pandemic has been the flexibility and some of the regulatory conditions under which we treat people for all kinds of health conditions, but just to highlight the challenges for folks with substance use disorders. I think this audience may be familiar that methadone is regulated at both the federal and state level, as the Senator just pointed out. By and large, people need to attend in person to receive their medication on a daily or near daily basis for sometimes as long as years. This pandemic has pushed both the federal government and enabled the state government to therefore suggest much more flexibility. And the programs in New York State have responded in the city by offering more what's called take-home doses to minimize people's need to attend in person, particularly during the riskiest time for us in the city. Additionally, the City Health Department, with our colleagues at the state, OASS, have been running a methadone delivery service for folks who are in isolation or need to quarantine. We've made deliveries to more than 1,500 New Yorkers who didn't otherwise have a way to access their medication. So we've been really aggressively trying to support our the individual patients to stay safe who were at risk themselves with medical conditions, and also to support the city's efforts to control spread. And the last thing I also just want to mention, what's been remarkable about this time is access to another medication called buprenorphine, which is another medication that's approved for the treatment of opioid use disorder. For the first time in the pandemic, both telephone and video care is possible to receive buprenorphine, including just a first visit or starting up that medication. And similarly, this has afforded a kind of flexibility. There aren't enough buprenorphine providers. You need a special certification to prescribe this medication. There's not enough in New York City, and so this helps people supports them to access the medication, and also minimizes their need to travel. So we, really, really would like these flexible regulations to continue. We think it is good for patients, good for New Yorkers, and will do important things like decreasing overdose because more people can access and then more easily stay in treatment.
I would just add, Dr. Koonens, I'm sorry.
No, please go ahead, Charlotte.
I would just add that, you know, I appreciate everything you're saying about the substance use prescribing. There's a mentality in this country that people who are in treatment are going to use those substances illegally, or they're going to sell them on the street. And there's an automatic mistrust of people who have a history of substance use disorders. And we really have to break through that. We have to recognize that people are, you know, it's anecdotal information at this point, but we know that more people are overdosing, more people are using, and more people are dying from substance use at this time than any time in history. And the same thing goes for suicide attempts and lethal completions. So we need to talk about and educate people about the stigma associated with this. Unfortunately, in our society, it took everyone having somebody who was a friend, a neighbor, a relative to use opioids before the epidemic became a mainstream issue. Well, behavioral health is now a mainstream issue. Nobody is going to say, I don't know somebody who hasn't suffered or who hasn't faced a behavioral health issue now that we've had this pandemic. So as painful as it is in terms of the silver lining, I'm hopeful that people will recognize that no one is immune from dealing with any of these issues. And behavioral health is something that everyone has to take care of and everybody needs to recognize. And people with substance use disorders and behavioral health issues are not different from your family, your neighbors, your friends. They are your friends, your neighbors, and your family. You just haven't known about it. So now that everyone has had some exposure and experience, I am hopeful that it will raise the consciousness and some better resources and attention will be paid to this going forward.
Charlotte, thank you for those words. I agree with everything you just said. Very powerful. Aaron, I did want to say a word or two on your question about seniors, because it's something that we're debating right now. We all understand that seniors face a special risk, and so the public health guidance has been that they avoid going out in public more than other groups. But we also know there's a mental health cost to that, in loneliness and isolation. And it seems as though this group is also facing the greatest food insecurity. And while we do have a pretty robust home delivery program for meals, it's not the same as warm cooked food. And anecdotally, I'm hearing disturbing reports of weight loss of homebound seniors who are getting food which they're not eating, or for whatever reason isn't adequate. And so there's a need now, I think, to begin to talk about having some in-person service for seniors amongst our incredible network of providers in New York, all of which have been entirely shut down for in-person service. I don't think we can just say that until there's a vaccine, there will be no in-person service at all for seniors. I think the benefit of hot meal provision would really lead to better nutrition for seniors. And I think the social emotional benefits of having some in-person contact, clearly it would have to be designed to have great safeguards. This would not be business as usual, but just as we're now talking about resuming in-person service for gyms, well, we've already done that for restaurants, for schools. I think we need to be talking now about a path to having some in-person service and for seniors. And there is now work being done on that in the council among providers. Definitely shout out to my to my colleague, Margaret Chen, who chairs our seniors committee, who's been leading on this. So stay tuned. I think we're going to be pushing. One positive note for seniors, on Monday, there's a hearing on extending SCREE eligibility requirements, which thanks to our colleagues in the state, we've been able to raise to much higher income cutoffs. This is senior citizen rent increase exemptions, extremely important for seniors to stay in their homes. And so the bill that's being heard Monday would extend out the higher income eligibility through 2022.
I want to get to a question here that is interesting from Muzzy Rosenblatt. She says, assuming there is no bailout of our city and our state.
That's a he. Muzzy's a he.
Oh, sorry. We will need to make some difficult choices and prioritize our efforts and our services. Where can we spend less with the least impact, and or where do we think cuts will most likely be made? So whoever wants to bite on that one first, please go right ahead.
Well, I mean, I'm with Muzzy on this as a provider. Traditionally, we've made the cuts where there have been the greatest consequences. Just think about COVID, right? I mean, the folks in the community in Mott Haven that I serve were at greater risk of contracting COVID and still are, and the consequences were greatest for them of contracting COVID. You put those two together, and that would suggest to me that you actually have to turn this upside down if we really care about the long view. If you're just thinking 3, 4, 5 months out, then it's probably not consequential. But if we're thinking about the long view, you have to, I think the calculus has to say, who, by not getting this service, who will reveal the greatest long-term consequences? And I would argue it'll be those communities, and we could all name them, where there's already been disinvestment. So that's where I come down on. I mean, I'm worried. I mean, our charter schools for children who are in the child welfare system. It's a school exclusively for kids in foster care or whose family, they're at risk of being placed in foster care. We know what their lives are like. A third of our kids go home to a homeless shelter at night. A third from our charter school, right? We know what their lives are like. We know to disinvest further in them, right? And if you don't buy this morally, let me put it out this way. It's smart, right? Because if you don't invest in them now, these kids and families will wind up in systems as they have traditionally with big black holes, and they're likely never to get out. And so I think we have to take the smart approach. And now is an opportunity where everybody's stepping back and taking a fresh look. Let's be smart about it this time. Let's invest where we know the lack of investment has had the greatest and most severe consequences.
So I don't know if Muzzy was asking about the broader budget or specifically the mental health budget. And on the more narrow question, I think I would defer to my colleagues here on where, if anywhere, there could be cuts. But I think more broadly, I'll just say that we're in a dire fiscal situation. It's true. We can't deny that. But we have to avoid diminution of services or we're really going to go into a downward spiral. And I would absolutely put behavioral health in the category of services we have to maintain, potentially even expand. And that's not going to be easy. But there are ways that we can save money in the budget that would avoid layoffs in critical areas like behavioral health. We are going to have to also look for new revenue. Personally, I would favor asking the wealthiest amongst us to pay a little bit more at this time of crisis to allow us to maintain critical services like behavioral health. And as we're of course fighting for federal help as well. And as a last option, I would support some limited borrowing with important safeguards in place for sure, so we can maintain services, especially to the most vulnerable. And that clearly is the work that the agencies all of you here represent are doing. And I'm certainly fighting to help keep your budgets whole at this time.
I think for the purposes of this panel, I think Muzzy was likely, talking about behavioral health specifically. So, of course, Charlotte, you can go ahead and make your point, but we should stay closer to that.
Yeah, I think when you're talking about funding and public policy, you have to look to the data. And I think when all is said and done, and we do have some data coming out of this, we're going to recognize that a big part of the spend in New York State, particularly in Medicaid, is among the Medicaid population. They use more medical services, they use more services. It's a more costly spend than any other portion of the population in Medicaid, even though they're disproportionately represented and they make up a much smaller group of the larger population of Medicaid enrollees. So if you look at the data, and the state has started to do this over the past several years, the answer is paying people based on outcomes. and being more careful about utilization of resources, not just spreading it around like fairy dust, but making sure that the people who are doing a good job and having good outcomes are the ones that are getting funded. And I think that that is about customer service and accountability. And I think that inspires confidence in taxpayers and communities, because they know that there is something meaningful coming from the investment being made. And historically, behavioral health providers have not been great at collecting and reporting out data, but we're getting more sophisticated. And I think that that's something that we should really pay attention to, both from a provider standpoint and a policy-making standpoint.
Yeah, let me also, Charlotte, I concur completely. I think that we need to, as government, pay for things that we know have good outcomes. Sort of reflecting back on also the prior conversation about primary care and specifically here, integrated care. I think this is in a time where certainly resources will be scarcer. We need to really make, in my view, make good on some of the promises around efficiencies and around coordination that you know, are known in some of the scientific literature, but we as healthcare providers, and I'm a former primary care doctor myself, haven't always implemented as well as we might. And so I guess I'm sort of reaching across the aisle, as it were, to my colleagues in the physical healthcare space, both from a policy point of view, from a provider point of view, is really there's great urgency, I think, to act together, to do some of the coordination and the integration that we know can work, that can achieve some of the better outcomes that Charlotte was referring to, that can achieve some of the cost savings that no doubt we are going to be asked to enact. We can, I think we can do it. I think it takes, you know, and maybe this is the opportunity, or one of the opportunities of this moment, as we are heading into some difficult financial times.
So we don't have that much time left. Wondering if we could talk a little bit about where you guys see things going now. We may not even be halfway through the pandemic. There's no vaccine yet. And even if there is one, we don't know quite what the prioritization will look like, how many doses will be available. So where do you see things going from here with mental health? Do you think it's likely to get worse before it gets better? How can we stop that from happening?
I want to answer, I actually been wanting to make this point for a little while, which is sort of, you know, we're clearly in it for a longer haul than any of us would like. Let's just say that. I think as we think about interventions and solutions for folks with behavioral health concerns or conditions, I think connecting it to the very important material support that's getting negotiated and at the federal level, that will certainly happen at the state level, is some of the things that we're doing to secure housing, to secure food, to secure income are actually interventions for mental health. And we often go to care appropriately. We need care, we need systems of care. So that work is mental health work. And so I want, you know, for those of you who are elected officials, and for those of you who are elected officials not on this Zoom, I encourage all of us to think about that as part of how we are promoting mental health during and after this pandemic, and how vital that is to our to New Yorkers' overall health. So that is a slightly side point that I've been wanting to make. There's others. I'll let others chime in though.
Yeah, I mean, I do think that to Dr. Kunis's point, we're going to have a broader view. The challenges that our kids and our families are going to reveal whenever the new normal arrives are going to evidence themselves in ways that we haven't seen before. And so our check the boxes of the questions and the assessments that we do, we're going to have to take a broader view. I think we're going to have to be better listeners coming out of this. I think folks are going to have many different stories, and connecting the dots are going to be a little bit more complicated. And so I just think that our traditional mindset of, I do this kind of practice, I do that kind of practice, we're going to have to take a step back from that and be good listeners and go into this clear-eyed, because I'm not, and we saw this in Puerto Rico. The way these issues revealed themselves among the folks of Puerto Rico could never have been predicted. And I'm not so sure the same's not going to happen here. So I think we be professional, but we take a step back and we listen first before we act.
If I could just add to that, I think that it's a real call to make sure that our advocacy is unified. When we talk about behavioral health, we're going to have to be stronger advocates than ever before, because we know that there's things that have to change, that can change. But unless the bureaucracy gets its house in order and allows us to make these changes, it won't work. We need to be focused on the federal level to make sure that the innovative things that we want to do, that we can do, and we don't have a strong or a big lag time. So the advocacy has always been important. One of the things that I've often been frustrated at as an elected official trying to pass legislation is sometimes that lack of a collective voice, that the issues are complicated. And you could imagine as a parent of a child with special needs, that you don't know how to navigate the government. You don't know how to lobby. You don't know what piece of legislation is going to make the difference. So I think it's up to us as leaders and involved in different organizations that we work together to really demand the issues that we've talked about, whether it's simply changing some regulations, whether it's paying our direct service professionals a living wage. These issues, we've got to be united. So many times, and I'm sure the council member could attest to this, you'll meet with a parent that just has a really bad situation, and they're telling you about it, and they're really expressing their experience and what's going on, but they don't leave there with a direct ask about, hey, Senator, Councilman, sign on to this bill, or we need this regulation changed. And that's something, it's a big calling to do, but one that I think is going to be needed in this environment, because we're going to have to be advocates in Albany. We're going to have to be advocates on the local level, and most importantly in Washington, to make sure that we're driving this ship and we don't let some bureaucrats just sit back and do business as usual.
If I could just add one brief optimistic note, I know we're almost out of time, out of this incredibly difficult period for mental health in the city and state, is that more people are talking about this than ever at all levels. Regular people, also very senior leaders who have big megaphones and are in the media, are talking about the mental health crisis. I do think that's helped to remove the stigma in an important way. I think potentially in an enduring way. I think it's going to make it easier for people to make that leap to get treatment. And from my perspective, I think it'll be easier to fight for funding and resources for this sector because people understand it. There's no one in this city or state who has not been touched by the mental health impact of this crisis. Nobody. And it's going to make it easier to have a broad-based political push to get the resources we need for what will be a long-term fight.
John is back, so I'm going to take that as this is the end of our discussion, and thank you to all the panelists.
Thank you, Erin. Thank you.
Thanks for having us.
Thank you.
Thank you.
Thank you.
Yeah, thank you, Erin. Thank you to our panelists. We are
Thanks
almost
so
out of
much.
time, but a few final notes before we close. We have another webinar, New York's Path to a Carbon-Free Future, on Monday, September 21st, 5 to 6 p.m. Registration is free and can be found on our website and in the chat. We also have our Brooklyn event, acknowledging our heroes in the borough, with a panel discussion on the pandemic with local leaders on Wednesday, September 23rd, 5 to 6 p.m. Registration is free as well. And on September 29th, we have our virtual Rebuilding New York Summit focused on construction, also free. You can sign on to that on our website as well. Thanks again to our sponsors, Google, Pharma, New York Foundling, Healthix, the Mental Health Association of Westchester, Primary Care Development Corporation, Montefiore Medical, and Albert Einstein College of Medicine, and Brown and Weinrub. Thanks again to all of our speakers, panelists, and to you, our listeners. This concludes our program.
Thank you.